Next, we will discuss glucose regulation. The brain needs the body to regulate blood glucose. Nearly every cell in the body requires insulin, and it's like the key that unlocks the glucose door. But the brain does not. Nearly every cell can make its own emergency supply of energy when glucose is unavailable, but the brain cannot. Glucose must always be available to enter the brain freely. The brain cannot make its own energy during hypoglycemic states. So there is an urgent need for serum glucose regulation. The pancreas is an organ that secretes the hormones insulin and glucagon. The liver, muscles, and fat store and release glucose. The pancreas has a dual function. The endocrine function secretes insulin and glucagon into the systemic blood to supply all the cells with these hormones of glucose regulation. However, its exocrine function secretes digestive enzymes into the intestines via ducts. So to distinguish between the two, it's important to notice that the endocrine function secretes hormones directly into the bloodstream to communicate with other organs. Whereas if we're referring to exocrine, what we're talking about is the secretion of digestive enzymes from one organ directly into another organ, bypassing the need for the hormone or the enzyme to go through the blood supply. The liver, muscles, and fat store glucose when they're stimulated by insulin, and they release glucose when they're stimulated by glucagon. Insulin is a potent anabolic hormone that is stimulated by the presence of serum glucose. It is produced by the beta cells in the pancreas. It also facilitates the storage of carbohydrate, fat, and protein nutrients into all cells. Insulin also augments the transport of potassium into the cells, and it is released in response to eating. The opposite of insulin is glucagon. It is a potent catabolic hormone that is inhibited by the presence of serum glucose, and it is produced by the alpha cells in the pancreas. Glucagon facilitates the release of carbohydrate, fat, and protein nutrients from the cells. It is released in response to low blood glucose, exercise, starvation, and stimulation of the sympathetic nervous system. The insulin-glucagon relation is that when the blood glucose level is high, the insulin is released and the glucagon is inhibited. Remember, insulin unlocks the cell to allow the glucose in. When the blood glucose levels are low, glucagon is released in order to raise blood glucose levels. Glucose moves out of the cell and into the bloodstream. Acute failure in glucose regulation can result in neurologic compromise, from confusion to coma and even brain death. High glucose levels are also a problem. They are an easier medium for infection, among other problems which we will be discussing shortly. Chronic failures in glucose regulation can result in vascular disease affecting nearly every organ in the body. Poor wound healing is one of the results, and neuropathy or nerve damage is another result. Poor glucose regulation can also cause nephropathy or kidney disease. Glucose regulation failures also cause atherosclerosis or clogging of the arteries, and retinal damage that can cause blindness. So, given that the two diseases are unrelated, Why do they share names, and what is the difference between diabetes mellitus and diabetes insipidus? Diabetes insipidus is a disease of antidiuretic hormone, and it directly involves the regulation of water within body system. Diabetes mellitus is a disease of glucose regulation. We'll discuss more about diabetes insipidus later. Type 1 diabetes is juvenile onset. These patients are usually insulin-dependent diabetics. Type 2 diabetics have an adult onset, and they are not insulin-dependent. In type 1, or the juvenile onset, these folks are dependent on insulin. Their problem is a failure to produce insulin, and they need insulin even if they're NPO, usually half of their regular dose. This is a pediatric disease, and the onset may be as an adult, but usually it's in childhood, and it does not go away. This is a chronic disease. However, type 2, or adult onset non-insulin dependent diabetes, has a slow, insidious onset that may occur over the course of years. The problem here is a failure of the cell insulin receptors to respond to insulin, as well as decreased insulin production. So these patients may use insulin during periods of hospitalization, surgery, or illness, but they are not insulin dependent. And this disease can also be regulated by behavior. For example, if they are newly diagnosed with a high blood sugar, if they have strict diet control, and possibly exercise, can keep the disease from coming on. The symptoms of both diabetes type 1 and type 2 are the same. These include polyuria, which is excess urination, polydipsia, which is excess thirst, polyphagia, which is excess hunger. These patients may have increased fatigue or lethargy. They may have recurrent infections and prolonged wound healing. They may present to the emergency room with seizures, or they may actually even be in a coma. So how do we diagnose diabetes? Well, elevated fasting blood glucose of greater than 126 is one of the determining factors. The patient may also demonstrate elevated triglyceride levels, usually greater than 150. And they may have a glucose tolerance test that shows results of 140 or greater. This test is performed by the patient getting a fasting blood glucose and then drinking some very high glucose solution and having their 2-hour plasma glucose level checked. Again, if this value is 140 or higher, it can be indicative of a diagnosis for diabetes. Hemoglobin A1C is another lab value. It shows the amount of glucose that has been attached to the hemoglobin molecule over the lifespan. And we know red blood cell lifespan is about 120 days. So the results of this test can reveal an overall glucose control for the past 120 days or 4 months.